Welcome everyone to today's webinar, Elevating the Strategic Impact of the Chief Pharmacy Officer. On behalf of Becker's Healthcare, thank you for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. We'll start today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded, and it will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or you're having trouble with the audio, please try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. And with that, I'm pleased to introduce today's moderator, Nicole Fauché, President, Clearway Health. Thanks for being here today, Nicole. I'll now turn the floor over to you.
Thank you, Randy. And thank you, Becker's Healthcare, for the opportunity to share this important topic today. We're very excited to speak with three pharmacy executives about trends and innovation in pharmacotherapy, how their organizations have derived significant outcomes by expanding their pharmacy services, and specifically how they navigated their careers to be a strategic partner within their executive teams. Born from Boston Medical Center, Clearway Health partners with hospitals and health systems to build and accelerate their specialty pharmacy programs. Our services create a high-performing and sustainable pharmacy asset. And as a result, we've seen pharmacy services become a pillar of their system's growth strategies and ongoing innovation. As pharmacy services grow in their financial contribution and expand their presence within the integrated care team, the role and visibility of the Chief Pharmacy Officer continues to evolve. Our panelists today have seen firsthand how their role has changed and the value of innovative pharmacy strategies. Today joining us, we have three esteemed colleagues of mine. First, we have Eric Baumeier from Children's National Hospital in Washington, D.C. Eric serves as a Chief Pharmacy Officer and is Vice President of Clinical Ancillary Services. In his role, he has system responsibilities for pharmacy, lab, nutrition, and facility services. I think by definition, quite an evolution, I think, of a pharmacy executive for sure. We also have David Twitchell, who is joining us from Boston Medical Center Health System. David is a Vice President and Chief Pharmacy Officer. And in his role, David oversees all pharmacy operations and clinical activity for a very wide range of pharmacy services, which include inpatient hospital services, their outpatient clinics, many retail pharmacies, specialty pharmacy, a mail order pharmacy that serves much of New England and many states throughout the US, and health insurance departments and ACO. Very broad in growth and in innovation at BMC and their pharmacy services. We also have Mo Carbat. Mo is a pharmacy executive with expertise in health system pharmacy services, supply chain operations, value-based care, and population health. Prior to joining us at Clearway Health, he is the Vice President of Pharmacy Services for SSM Health, and is currently the Vice President of Industry Affairs for Clearway Health, where he leads our strategies relationships specifically with payers, PBMs, and manufacturers. He also leads our accreditation implementation services. I cannot say thank you enough to the three of you for sharing your stories and insights with us today. But before we jump in, I do want to provide a reminder to the audience. Please share any questions you have as we go through this. We'll have lots of different ideas and would love to hear what might be on your mind as we go through this. So the first question is, I talked a little bit about your backgrounds, but we really want to hear from you. How has your career evolved as a pharmacy executive? And Eric, I'm going to start with you because I think yours, as I said, your title and all the areas you have responsibility for is very vast. If you wouldn't mind kicking us off and telling us a little bit about your history and your career trajectory.
Thank you, Nicole, and really thank you for this opportunity, and honored to be a part of this esteemed panel. So Nicole and team, I could tell you mine is a very unique story, and I'm going to say I've done it all in pharmacy, but at a very early, my first introduction to pharmacy was literally as a messenger at a hospital in Brooklyn, Methodist Hospital. And from there, we were still on paper back then, so you could imagine the inefficiencies and so forth. So going from paper to automation or an actual EHR, I was actually the informatics pharmacist, which quickly climbed to informatics manager, then informatics director. And then from there, as we all have, EHR has been basically the foundation of pharmacy. I then quickly transitioned to a director of pharmacy of the actual hospital. In between that, believe it or not, I had a weekend job at an animal hospital. And I can share with you that you don't know pharmacy until you have that one patient, and when I mean a patient, animal, that comes in. It was a New York City horse that needed care. And of course, you know, it's immediate, turn to the books, turn to the drugs. I had to dose ampicillin. And just to understand pharmacy in that moment, I think it really shaped where I went with my career. What I learned at that animal hospital there, the passion and compassion that the staff at an animal hospital had was by far extra compared to the humans. And so you learn to give care in a way, and you learn to be compassionate with people and patients while really delivering that excellent care. So that was a big piece. From there, continued working at our hospital there in Methodist, and I acquired some services in lab, and I was also in charge of regulatory affairs with primarily in the ED, so Joint Commission, CMS. I became very knowledgeable the hard way, having visits and making sure we not end up with citations. And it just quickly elevated my career, and we just started expanding. We actually moved into a high series of automation. And then from there, continued to grow. We actually, before I left Methodist, we opened a retail pharmacy, not specialty, but a retail. And it sort of gave me that wide spectrum view of the profession. Moving on, coming here to Washington, D.C. at Children's National, that was a huge step, huge leap, huge step, never left New York, and here I am. And I think coming here really raised the antennas of the need, where all that work and experience I had at Methodist really prepared me to bring this hospital to the next phase. So coming in as a chief of pharmacy here allowed me to apply what I've learned and really elevate the department, expand, improve their statistics, our efficiency, and that quickly led me to doing the same for the laboratory department, food and nutrition, and now facilities at this hospital. So I think with that, it just put me in the right spot to really manage a lot of folks, but all leading towards one common goal, which the hospital had, that mission of our hospital.
It's a great story. I think there's a lot in yours. I think the expansiveness and the places that you said yes to probably things that were a bit unusual, I think probably paved the way. I don't know that we'll find commonality with the veterinary pharmacy with our other two guests, but I'm sure there's a lot of other commonalities, especially around some of the paper. I saw David nodding, and I've heard some of his stories. Yeah. So David, if you would share a little bit about your career trajectory and its evolution over the last bit of time.
Sure. Yeah. No. And thank you all for having me. Yes, I share Eric's story of starting on paper. In fact, my career started in my kind of career into pharmacy started as a technician, actually. And I have an older sister who's a pharmacist who said, David, you can't select to be a pharmacist unless you've worked in a pharmacy, you understand what that means. And so, started at a locally owned independent pharmacy, counting prescriptions and filling the shelves and doing all the basics. Entered the pharmacy profession as a pharmacist out in Colorado as a clinical care specialist. But I will say, and one of the things that I enjoyed hearing Eric talk about is having exposure and frontline experience, was really kind of, I would say, a formational experience for me. I started in the IV room. And it taught me things of don't make clindamycin 450 milligrams, which only makes sense to my pharmacy friends, of why that doesn't make sense. And then grew from there. And like Eric, the other thing, and Nicole, you said it, really my opportunity to become a critical care specialist was, and I'll briefly share a story, which was I was the junior pharmacist working in the ICU pharmacy as one of the order entry and delivery pharmacists. And we had just gotten an opportunity to create a critical care specialist role that would have some responsibilities for rounding. Every pharmacist besides me was asked first because they were senior to me. And their question was all the same. We were in the same room and they said, well, what's the extra pay? And the answer was none. This is just an opportunity. And I said, yes. I stepped forward for no pay and no title, but some opportunity to do something interesting. And that story has followed me through my career. So there, it was a place called Swedish Medical Center in Englewood, Colorado, level 1 trauma, where I was the critical care specialist for a 43-bed ICU. And for those who have worked in the space, 43 beds and 1 pharmacist is a lot in an ICU. But a great experience for me, formational and like how clinical pharmacy work, what makes an impact, how do you make the case to a place like HCA to maintain a clinical pharmacy program. And my flip to administration was my desire to expand that, to say, if I can, as a clinical pharmacy specialist, improve the care that we're providing to patients, lower costs, improve the outcomes, for the patient, the physician, the organization I serve, couldn't we do more of that? Isn't there more opportunity to bring that out? And I found that in order to do that, I felt like I needed a leadership role to have the influence necessary to do that. And so had a friend, and I say make lots of friends and treat people well, because a friend and a colleague who became a nurse manager and nurse director and then a chief nurse, when their pharmacy director left, she called me. And so I had an opportunity to join. My friend and chief nursing officer, Eric Rosito, called me and said, our director's leaving, and took an opportunity. I came to Boston because I'm from the East Coast and had 2 kids out in Colorado, but decided to get close to grandma and grandpa here on the East Coast. And BMC came up as an opportunity where my skill set from HCA, which was, great productivity management otherwise, aligned with a bit of luck and timing with what BMC needed at the time, and came here. The story here, there was a lot to do on the inpatient pharmacies here, great clinical program, great history. What we then had to evolve to was to solve a financial crisis that we were facing. And so specialty pharmacy emerged as an important way that we were going to solve that. And though I had little experience, I again kind of said yes to the opportunity, but said, hey, look, I don't know how to run a retail pharmacy. The last time I was in one, I was a tech at Stop and Shop Pharmacies, which was a grocery store on the East Coast. And they said, yeah, we'll find some help, but please take the job, again, for no extra pay at the time. And away we went. And so the story, and others will tell the story, it became an important part of my career to help, lead the building of and creation of a specialty pharmacy here, then eventually evolved into something that we're talking about today. So, and what I'll end with is, throughout that, took opportunities to take my clinical experience and put that into everything that we did, and how I thought about how we influence the organization and some of the positive impacts that we had that perhaps weren't obvious when we started, like the clinical impact and the impact on pop health that we'll talk about a little bit later, I think. And so exciting to see kind of that evolve, and where we are now is working on new and innovative things that may be outside of pharmacy. That's an exciting kind of point that I'm at today. So I'll stop there. I know that we've got lots of time.
I think that what I've seen, both through your actions and working with our colleagues at BMC, is that there's been a very intentional approach to innovation in navigating what can really kind of occur in the career when you start thinking about what's possible. And so I've seen, you, David, work through a lot of that and create so much innovation. And it, as a result, I think, pave a way for the role that you've been describing here. Mo, you have a unique story in transitioning from being in the provider space and now more outside, but would love to hear a little bit about your background and career trajectory as well.
Yeah, thank you, Nicole. Just like David and Eric, my career journey took me through many settings within the pharmacy space. Initially, after I graduated from pharmacy school, for a couple of years, I worked in pharma, and also I was a GMP certified auditor. So I was working closely with manufacturers too, many years ago. But then my clinical pharmacy or patient care pharmacy career started at a retail pharmacy, at a pharmacy chain in Milwaukee. I was a staff pharmacist, then a pharmacy manager. So I've seen the retail side more than just being a tech, David. So I worked as a staff pharmacist and a manager, working with a great team of pharmacy technicians and interns at the time. But then I wanted always to get closer to the patients. So I transitioned to a hospital pharmacy job. I remember these days working in a hospital pharmacy in a basement somewhere where you basically react to physician orders and respond to codes. And then I transitioned to another health system also here in the Wisconsin area. And it's there when I was asked to become a manager. And at the time I said, well, I don't think I want to leave the bedside. I don't want to leave patient care. I love pharmacy. I certainly can and will perhaps be happy managing my team, but I would like to still be close to the patients. But then eventually I said, yeah, okay, I'll try it, just like you, David. I don't even remember now if they offered a pay increase or not, but it wasn't the point at all. And at the time, I said, well, they don't teach us business management in pharmacy school. And I went back to school and I got my MBA from the University of Wisconsin-Milwaukee. I still remember the time when the folks at the college, at the school said, well, you're a pharmacist. Why do you want to do an MBA? That's not the way we see student candidates here. But that was the beginning of a trend, which we'll talk about during today's presentation, where healthcare executives start from a clinical kind of role or clinical capacity, and they make it into management and into an executive role. And sure enough, after that, we began to see MBA programs, directed mainly at healthcare executives like physicians, pharmacists, and nurses. After that, I transitioned in my leadership career from a manager to a director, regional director. Then I joined another health system, also in the Wisconsin area, SSM Health, at a time when the system itself was growing and expanding and adding or merging with other health systems here in the Wisconsin market. And that's where my career really began to take a turn in a different direction, where I began to see patient care in its totality. Because for our health system here in Wisconsin back in the day, for SSM of Wisconsin, is where we operated in addition to hospitals and clinics. We also operated a health plan, and we also worked very closely with the PBM. So I basically saw the entire spectrum. And for the first time, yes, on one hand, we provided care to patients and we billed for that care, whether it's a prescription or an infusion drug. But in the same time, I was in a position to also see the way we pay for that service. So you want to deliver the best care and you want to collect revenue on it, but at the same time, you're paying for it. So that's where the concept of value-based care came to mind at the time. And during that time is when I oversaw inpatient pharmacy services, retail, specialty, home infusion, and as I mentioned, working closely with our health plan and PBM sister companies. And after that, I joined Clearway Health. And again, it was to me another natural step in my transition, where I felt that at that time it is time now to bring my expertise and knowledge to many health systems all at the same time, instead of working for one health system at a time, which was a job I enjoyed and loved for many years. And now here at Clearway, I have the pleasure of working with David and Eric and many other pharmacy executives serving and supporting health systems across the country.
Thank you, Mo. Very good. We've laid the foundation, lots of different backgrounds and career trajectories amongst just the three of you. But sometimes the industry supports change or creates change, for that matter. And so I'd like to talk for a little bit. We're going to start with David on this question, but just to talk for a minute, about some of the more significant things that have been happening within the pharmaceutical industry over the last few years that is really helping support the elevation of this role. And then we'd really like to hear as to why you think this elevation is so critical to patients and health systems on both. And so, Dave, if you wouldn't mind kicking us off on this question.
Yeah, I think it does feel like a lot is happening to us, right? And then that ends up shaping it. Sometimes, though, for the better. I think in pharmacy, and what has I think been a big influence, my observation of the market right now is kind of three big things have happened. One is the rising costs. So, pharmacy used to be this like small kind of insignificant portion of the spend. People used to say, look, you kind of spend indefinitely on pharmacy because the real problem and the real kind of important strategic things are the hospital and the physician clinics and surgery. It's no longer true. As an example, at our own health plan, we cover about 750,000 lives across 2 states. 25% of every dollar we spend is on prescription drug. If you add medically administered drug, that's another 10%. So a huge portion, a third, 25% to a third of every dollar we spend in the United States is on a drug. That doesn't raise kind of the importance of what's going on. And while that is a system of pharmacists being kind of absent from the executive role, it has emerged as a need because of that happening. The second thing that I think is also happening is increased complexity. So, when we were talking, I don't know, a few months ago, we were noting, I remember, Eric, you and I were talking about the most expensive therapy that was on the market back when you and I were coming out of school was like Nexium, the purple pill, and the ads, and it was a $40 a pop pill, and I couldn't even believe that's how much somebody would pay for a drug for heartburn. Well, today, the expense of the drug, and by the way, it was a kind of an innovative way to treat heartburn. But today you have drugs that cure hepatitis C. You have a gene therapy that promises to cure sickle cell disease. I mean, like, these are amazing therapies, and the way that we're going to treat them has changed from, well, there's a surgical intervention, a medical intervention, to there's really the drug is going to be the key item. But to do that, you're going to have a drug expert at the table that helps draw you through that process in a way that means that you have a great outcome. That wasn't true before, it is true now. The third is that the industry is changing. And so my observation of that is that there's this massive industry consolidation that really, because of the dollar and the spend, the 25%, you're seeing, companies, a small kind of Rhode Island chain of pharmacies called CVS, if you've heard of them, all of a sudden owns Aetna and has a vertical that includes a PBM that controls 30% of the prescriptions that flow through the United States and has primary care clinics and a hub services that they intend to be the front door of medicine. Well, if you didn't before, you might look at your pharmacist at your health system and say, how do we respond to this? Or how does a health system operate in this environment where pharmacy is driving so many of the decisions at the health system level across the United States? We need a pharmacy executive to help lead us and shape our strategy to address and face off with those realities so that you can address the cost of those things. You can realize some revenue and maybe margin to help your system from those things. You can idealize the outcomes for your patient in the extent you operate in population health and have value-based care, as Mo was alluding to. You better have a pharmacist at the table. And so I think, it's so critical to have a pharmacist executive at the table to help your health system make those decisions in that framing of like what's happening. It's happening to you or with you. And if you have a pharmacy executive at the table, then it's with you and you can help, form your place on that. So that's my opinion of what's happened and how critical it is. But
David, I think I just want to touch a little bit on what David just said, and you so eloquently framed it. You said cost, complexity, and this, I'm going to call it vertical monopolies that are forming, right? Because that's a whole other probably seminar, webinar that we need to talk about. But bringing it down to the patient level, you think about the evolution of pharmacy. We went from treating symptoms, right, and now treatment. So people with diabetes are now living full, fruitful lives. HIV, full, fruitful lives, and a host of others, to these cures, and that evolution of the business in itself, not having an executive that can really operate at all three levels, because we're doing all three simultaneously with some sort of fiduciary responsibility, stewardship that has to happen. No one can do that better but than a pharmacist. And so I think now a hospital that does not have a pharmacist at the C-suite or A suite, whatever, however you call it in your institution, that's going to hurt the system. It's really, it's not a need, it's an essential a role that's needed at the table to help people navigate and make strategic decisions for organizations.
Yeah, absolutely. I agree with you, Eric. I agree with you, David, too. I mean, according to the CDC, 71.9% of all physician visits involve a medication therapy, a prescription or a medication used in office. So, and this wasn't the case 30 or 40 years ago. So pharmacy now is becoming, medication use is becoming now one of the, a key area in patient care in general. So pharmacy services and products are needed, are used everywhere in hospitals, in clinics, in the community. And therefore, health systems are now getting to a point where pharmacy executives need to be at the table because financially, pharmacy is becoming so significant, like you mentioned, David, and it's also having a huge impact on patient care outcomes and population health in general. So, and that's why more and more health systems are asking pharmacy leaders to get out of the basement and come to the table and tell us more about what you guys are doing and how can you, if we have to make these major investments in pharmacy, how can we get the most out of them in terms of patient care and in terms of also helping the health system financially as well. So I'm not surprised to see the evolution of where pharmacy executives are today.
Yeah, that is so true. And I get the little pun also, Mo, about getting out of the basement from pharmacy. It seems to be figurative and literal. One of the things that I think you all just kind of described, which is so important, is when things are happening to you, you act in one way. And when you act with it, you act another way. But when you are the innovator or you're the leader of what's happening, it's a completely different dynamic. And in each of your organizations, there have been moments where pharmacy, many moments, and those are going to continue to grow, where pharmacy was the starting point of an innovative solution, process, tool, whatever the case may be. And so I really want to hear about that. I think executives outside of pharmacy need to hear this more, right? How did this start in pharmacy? And so, Mo, I'm going to kick off with, if you would kick us off here, like talk a little bit about, a specific example or an experience where something really was generated within the team that served the larger organization.
Yeah, absolutely. I believe one of the key innovations is optimizing medication therapy. It may not sound too innovative, but if you look at it, it is. When you, again, go back to some of the key statistics we look at daily and weekly. So according to the CDC, 48.6%, imagine that, almost half of the population took at least one prescription drug in the past 30 days. And if you look at the population over 40 years old, the percentage goes up to 69%. So medication use is everywhere. Now we are basically seeing more and more medications come to market. When I looked this morning, 88 new drug entities or new drugs and biologics were approved by the FDA this year alone. So the sheer volume of pharmacy products and services on the market make it really mandatory for health systems to optimize these programs and services to improve patient care. And what I mean by that, I remember one time I was talking to our CFO back in a prior life, and I was asking him, should we go with product A or product B? And he was saying, well, ideally, we should go with nothing. If we can keep the patient healthy and not need product A or B, that's the best scenario. And why? Because when you are at a health system that has care delivery assets and a payer, ultimately, you want to keep your patients healthy and lower utilization. That's better population health, better value-based care, and it's better also for healthcare finance. So that's why medication therapy management is a key innovation nowadays, because unlike before in a fee-for-service world, where the more you do, the more you get paid, now it's not the case. Now you want to take care of your patients, optimize their care, and try to keep them healthy. And if they need medications, which 60-70% of patients do, how can you optimize their therapy so they can get the most out of it with the least amount of side effects and at the lowest cost possible? So I know it's like a conundrum: better care, better safety, and lower cost. The IHI used to refer to it as the triple aim, but it's very, very true. Health systems are now having to focus on all three, or you add the fourth if you look at also keeping patients and caregivers also engaged and satisfied. I think this is one of our key innovations: optimizing medication therapy and medication management for patients. And I'm sure, David, also with you operating with a health plan, also with your health system, I'm sure you're seeing the balance between the provider and the payer sides.
Thank you, Mo. I wasn't sure if Eric was about to talk. Plus, my computer gives feedback, so I'm always on mute. But Mo, it's just playing off what you just said. We've seen exactly that, and one of the innovations. I completely agree with the medication therapy management. It just brought an example to mind where so again, for our health plan, we are fully capitated. We get an amount of money, and then that is our money to spend, whether somebody's on a drug or not. And I'll briefly tell this story on kind of what we call optimizing instead of maximizing the benefit. We noticed in a quarter, which was 2018, 2019, I've forgotten exactly the year, but for a quarter, we had about 2,000 people, members, on the drug Vivitrol, a monthly therapy for medication-assisted therapy for substance use disorder. And we spent about $3.5 million in that quarter for 2,000 members. The average persistence rate, so how long the person was on Vivitrol, was about 2 months. If you know anything about medication-assisted therapy, that's not very good. If somebody's on that type of drug for 2 months, for really less than 6 months, you probably haven't had an opportunity to engage the patient, behavioral modifications, other therapies and treatments. They probably need to be on it for longer than that, which means as they get off of the therapy, if they're off in 2 months, that means they're back in the hospital, they're overdosing, they're back to using the drug that they have a disorder around. So we really felt like it was a problem to solve. What we did is we brought that all into our own specialty pharmacy and said, we're going to have a care platform around this. We're going to have people dedicated to it. We had 4 people dedicated to about 900 patients or the 2,000 members that were on the drug. So they all came into one program. Well, fast forward a year after we consolidated it, we had 3,000 members, more members, 50% increase in the number of members using it. Our persistence rate was over 6 months. So it was about 6.5 months, meaning we had many people on it now successfully over the chronic basis. And I think this is the most interesting part. Our quarterly spend went down to $2.5 million. And so that triple aim became a reality to say we can provide better care, we can provide better outcomes to the patients. But what we had to do was eliminate kind of the incentive that was out there to just maximize what was happening. The response to a lost drug or to a patient not showing up was just more drug, or the patient perhaps using the drug in a way that they shouldn't have or not understanding how to do it. We solved those through a series of things, and I can certainly follow up with detail if necessary. But I just thought it was a great example to just like maybe crystallize Mo's great example of medication therapy management coming out of pharmacy. Like that was a entirely pharmacy-led way that we improved the care of thousands of patients across a couple of states here in New England. Thanks, Mo.
David, that was great, and I'm just listening to your numbers. It's like to have those great outcomes with the financial gain. That's like win-win. So when I think about this question, Nicole and team, like what innovations, I think pivoting the conversation from what we were just speaking about, I think about hospital flow throughput. And when you think about that, pharmacists at the beginning of the process and at the end of the process can only mean a good thing. And what I mean by that, you have a pharmacist that's doing a medication history in your ER. You have a pharmacist that's assisting with medication reconciliation, potentially in the ER, or an admission pharmacist. You have in the ER, you're basically responding to codes, traumas. Once again, pharmacists at the front door of your organization. And as you continue through the flow and throughput of the hospital, we're also at the end. We're in the middle and we're at the end, whereby we're looking at discharge counseling. We're optimizing meds throughout the hospital stay, like Mo talked about. But then also on the tail end, now you're continuing the medication reconciliation. That continuity of care continues. You can swiftly navigate the patient through, improving your throughput. Now you're working in the prior authorization team. You're educating the patient. You're doing those callbacks. You're potentially, I won't use the word, but highly suggesting your own pharmacy for your, discharge prescriptions. I mean, we're throughout the entire process. So how we impact the health system is huge, ginormous. And I think knowing our places in those specific roles can really help with the end figures, those dollars, the financial improvements that we all seek to get with our profession.
Absolutely. So I think there's no better way in some cases. Healthcare is known for driving wellness outcomes, healing, right? So there's a lot of attention on patient outcomes, but there's no doubt that in the day and age where hospitals are suffering soft margins, negative margins, difficulties in the financial environment, the way to gain some attention from the executive team or to join the C-suites is demonstrate ways that you can move from a cost center to a revenue center, or a place that you contribute healthily to the operating margin of the system. So if you would, I'd really like to, start with David on this, because I think the trajectory at BMC that's been going on now for over 10 years is just a really great case study on what this means. So if you wouldn't mind kicking us off, like how can the pharmacy shift? Like, what are some of the levers that were pulled to really transcend what pharmacy means to the system from a financial standpoint?
Yeah, I'm happy to, and it's worth, we all kind of, and I think, all three of us just, I shared my current title. It may be worth, I'll back up a little bit because it's part of this story. I started here as the inpatient director of pharmacy. That's what I was hired to do. The whole transition to retail actually was another luck and timing thing where the Thursday before I started, I got a call from my then boss who said, "Hey, we have a problem. Could you come in on Thursday?" And I thought, oh, geez, they regret hiring me or something. That's the problem. But in reality, they said, "We have a problem with the retail pharmacies. There's some, the audit had the following findings. Could you just take it over?" And that's my slightly longer version of it. And so what I would say is here, the thing that I had to think about was, look, it was true in my clinical career. It was true in kind of my early career as a director. But here, where I had an opportunity to expand that, I had to think about, like, what is the organization trying to solve? What is the CEO thinking about and worried about? What is the COO and the CFO worried about? And how do I align my work to that need? And then what emerged was this opportunity, when I thought in those terms, not like what does pharmacy need or how many interventions can I document in the EMR, but like what is actually Kate Walsh struggling with right now? And it was a $150 million gap. And I was looking at the fact that our pharmacies had this massive opportunity to grow. And these things aligned, right? Kate had a problem and I had a solution. And when I connected those two things, well, I'll tell you, like all of a sudden I was invited to a lot of meetings with Kate and Alistair and to say, how are we going to get at that? What is the plan for that? Do we need to open 30 pharmacies? Like they started to ask me what I needed. I like to say, pharmacy is on the top 3 of strategic things. Eric, I think it's true at your organization as well. But what I would say is our success in growing our pharmacy from the 20 million to the 800 million or wherever we are now was not because that didn't cause it to be part of the strategy. It became that big because Kate and Alistair put it on the top of the list. And then organizational things came behind it. And that enabled me to then grow and kind of like be showing my way of contributing to something that the organization cared for. So the first thing was like, building a coalition and getting support and making sure people had awareness of everything that was out there. And then chasing that opportunity and making sure that we delivered it and create a system that made it was sustainable and otherwise. So I think that was an important way to shift from, hey, pharmacy is a cost center. You want to minimize that as much as possible, get patients through the hospital without doing, as much pharmacy as you can, to how do we invest in pharmacy to grow it because it's clearly part of the solution to the problem that we're solving. I think the second thing that happened, Nicole, because there's the population health portion of this, is in the process, and I give a lot of credit to Bhavesh, who really ideated a lot of this stuff, and me, who both had a clinical background, him in oncology, me in critical care. We thought about the other party that was involved is the providers. Like if you told a physician at your hospital, I have an idea to make the hospital more money, you might not get the best reaction from the physician who's struggling with their day-to-day. They're seeing 19 patients in a session. They have a hard job. But if you said to them, I have a way to make your patients better and to make your life easier, well, all of a sudden you might get a lot more buy-in. And so, that's how we started. And because we started with a clinical program, and Clearway now lives this every day, it became this side effect that we didn't totally anticipate, which is that it so dramatically improved the care of the patient, the Vivitrol example being just one of many, that it became a solution to lots of clinical problems that we had. And as we emerged in 2018 with a ACO in the Medicaid space, where it was really important that we had to control costs and improve care, actually take care of patients in a better way to save ourselves money, save the state money, and deliver better healthcare to a population we care about, pharmacy emerged as this very important tool in the toolbox to enable those outcomes. So, I want to be brief here, but like I think those elements, it was really aligning our work to the needs of the organization, both then and having some forethought on designing it for a system in the future and adapting to the needs as the organization emerged with an ACO and otherwise. So I think my colleagues have some thoughts on this too, though.
I do. I think, you're hitting it on the nose, David. I think you use the words collaborating, and I think I also would add educating the C-suite. They don't know what they don't know at this point. And even as early, you may not have a retail solution or so forth, but even within just a plain hospital with revenue cycle in itself and how the bills hit and what we need to do and all the different coding that's involved, even down to impacting the case mix index of a hospital. You know, having an indication next to a drug and having those coders say, hey, wait a minute, they just gave this patient this drug for headache. I don't see a note about headache. Well, guess what? We can't bill for headache because there's no note, but you have a coder that's prompting the provider to say, we need to write a note on here so we can elevate the bill. I mean, that's a huge impact. And that's something we can start just by having clinical pharmacists on the floors, making sure that there's an indication, there's a note for everything that we're giving out to patients. So educating the C-suite for one, and really showing them where the values are and where those unbuilt areas are, I think really is a great way in opening and making sure that margins are improved for a hospital. So there's just so many things we can do.
Yeah, I agree with you 100%. If you ask any healthcare executive, where should we take care of a patient? They will tell you we should take care of them in an outpatient setting, better than being in an inpatient bed if we can. And better than if it's even better to take care of them at home if we can. So healthcare executives agree that we should take care of patients at the lowest cost site of care. And I'm sure payers agree with that and like that too, because that means they pay less for the service. And if we as pharmacy executives continue to advise our executive teams at our hospitals and health systems that through pharmacy management, through our pharmacy services, we can provide care to patients in the lowest cost site of care, hopefully the home or perhaps the outpatient setting, in a way that keeps them healthy or healthier, so they don't need an ER visit or an inpatient stay. And this is now even more important than ever before, because these medications that come to market now are far more expensive than ever. So it becomes like, how do you justify the investment or for a payer to include an expensive medication on their formulary if it's going to be that expensive, unless it's justified by improving patient care and reducing downstream costs. So in our pharmacy programs, imagine if we provide optimal care to hepatitis C patients and they adhere to the regimen, they complete their course, they clear the virus, this patient will live a healthier life for the rest of their life. And they will not need any further care related to hepatitis, and they will not need costly interventions like a transplant. Imagine when it comes to, for example, there are some biologics used for allergy, for severe allergy, for severe asthma, I should say. We used to look at them and say, hey, physician, couldn't you just use an oral steroid that's cheaper? Sure, we used it once or twice. The patient failed. Now what? So when we begin optimize the care of the patient and still dispense this expensive biologic in an outpatient setting in the office or at home, we will prevent, through this treatment, we will likely prevent an ER visit, an exacerbation attack of asthma, and an ER visit and potentially an inpatient stay. So for the health system and the payer, yes, there may be an upfront investment for the cost of the therapy, but the downstream savings will more than pay for it. So more than outweigh it. And not to mention also, so in doing it in this fashion, the health system can generate revenue from the pharmacy services because the work that we do is so impactful. We need to get the revenue from it so the health system can keep these services running. And in the same time, how can we optimize patient care, improve population health so they need less and less interventions from that disease we're treating? Sorry for this long-winded answer.
Well, I think what's really great about our discussion is a few things. One, there's a lot of passion around what's happening in pharmacy in the industry, which creates a lot of excitement. The second is, I think each organization, each health system, each of your areas of expertise, there's multiple areas of opportunity for growth and enhancement of these services. So it's great to hear them all. It's also very easy to get caught up in our stories. I am going to move us to our last questions. We have some time for some of the questions that we have. If you would, I think that there's a lot of paths to success in pharmacy, and there's a lot of paths to the seats that you all are in, and perhaps even other aspirations you all have for the seats that you have or your future. When you're thinking about individuals coming up as a pharmacy executive at various places in their career right now, what kind of advice do you have both for the individuals looking to grow their career and the health systems looking to really elevate the role of pharmacy in their space? And I want each of you to sort of respond. So I'm going to have you start, Eric, if you wouldn't mind. Just kind of what's your thoughts for everybody here listening today?
You know, I can go in so many different angles with this question. I think the first part, just how do we elevate the pharmacy? I think sometimes you don't necessarily need an invitation. You know, you find those meetings and you'd say, hey, can I sit in? You know, and believe it or not, you'll know if you belong there. And after 15 minutes, you don't have something to add. And I think part of my success with this is I just got involved more than I would have wanted to, but in a positive way, where pharmacists are, of course, I'm biased, but we're so logical in our thinking because we're so used to minding our pockets, being efficient and effective. And when you apply those principles in any type of problem in an organization, you're going to end up with great positive results. So once you start doing that and you show the value of that, I think you won't need to invite yourself. You will find yourself being invited to meetings to solve problems. And you know, no is a nice word, but you got to know when to say no. And when you're not at a position where no has to be strategic. It should be yes, 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 and you work it to a way where you position the pharmacy, you position the department, you position yourself to be a value add to wherever it is that you are. And I think if you're at a meeting, and no matter what, even if it's internal, if you are not a value add to that meeting, then it's time to rethink that meeting. It's time to rethink the players or the charter of that meeting. I think that's the way I'd like to start us off with elevating us, elevating the pharmacy, elevating the profession.
I love that, Eric, and I think you covered what I wanted to cover from, like, if you're the pharmacist on the call looking for a way to find your way into an elevated role. Like, I would just tell you to listen to Eric and take those opportunities. I think, if I flip the question to what advice for hospitals and health systems looking to elevate the pharmacy. So if you're on the other side of that call and you're the health system executive or the physician saying, I want more pharmacy, I would say, take the time to present the issues that your health system is facing in a very honest way to your pharmacy leader and say, I want you to put yourself in my seat and solve this problem. We have a $150 million deficit this year. We are struggling to, get out of an upside down MLR in our pop health product. Our at-risk, performance is not what it should be. How would you solve this? You control the world. You can put a pharmacist, you can put a nurse, you can put a social worker. It's your choice. You may be surprised, if you're listening and haven't engaged your pharmacy leader before, you may be surprised how thoughtful that pharmacy leader will be, how, systematic, logical, as Eric said. They tend to take a very structured, protocolized approach to things. And I think you'll enjoy that output. If you give them the opportunity and give them that framing, they'll find their way into that. And then otherwise, I would just, agree with Eric on the, to take the opportunities. The other thing I might add is just to be patient. You're on the phone and you might, I know people are like, how do I get your job? And I'm like, well, wait 20 years. Like I know I look like I'm in my 20s and I'm very young and spry, but I've been at this for a long time. I've been in pharmacy for 25 years. And I think, take the time to do well at the opportunity you have. I was at the bedside for 5 years, full time, every day. And I was at the inpatient director role for, 5 years, every day, like making that better, making an impact. It evolves over time, and it's very easy to kind of look through the lens of like, boy, that person's already there. If you're kind of if you're in the grind right now, just keep your head down, do a good job, and it'll come.
David, I'm sorry. I just had to jump in. Being patient is such an important key factor. I always tell my students, delayed is not denied, guys. Just because you're delayed does not mean it's not going to happen. Delayed is not denied. And you never know. We can create a role. If you're in a role, if you're in a hospital where you have the creative art of adding different types of positions, be that person, get creative, present that. I just loved your patient story. Sorry, Mo, I didn't want to interrupt.
No, that's all right. Yeah, thank you. I agree with you. Be patient, but also be a subject matter expert. Healthcare executives will come to you as the pharmacy executive to be their expert, their advisor, to help the health system optimize pharmacy care, improve patient care, and generate revenue in the same time. So I remember once sitting at an executive table, and one of the executives on my side said, "I didn't even remember having pharmacy at this table ever." And I said, "Well, I was invited. I don't know why they invited me, but eventually I realized that the pharmacy spend was just going, I don't want to say out of control, but because of all of the new drugs on the market, just pharmacy spend became a key component for our health plan. So, and from that point on, we began thinking, okay, if we have to spend or make these investments when it comes to pharmacy services, how can we do them internally? So we take care of our patients in an integrated fashion so we can deliver the program and the service, make sure that our patients are taken care of in an optimal manner, and keep the revenue too, if there is revenue. And if it's savings, if you happen to own the health plan, either way, you get the financial benefit. And from that point on, health systems are now, like the ones I worked for, did not look back. And pharmacy as an enterprise continued to grow. And I believe that's going to be the way going forward for all health systems. My advice to you, if you're a healthcare executive on this call, if you haven't invited your pharmacy executive to the table, please do so.
Excellent. Great call out. Thank you all. Okay, we have a couple of questions. We've got about 8 minutes for questions for my colleagues here to have a bit of a time check. So let's get through as many of these as we possibly can. The first one I'm going to direct to you, Eric. Okay. So this is a really great question. Traditionally, hospital pharmacies are inpatient focused. How have you identified pharmacy talent to strengthen your business acumen in the ambulatory pharmacy strategy? Have you hired for the roles? Have you partnered for them? Like, what has been your path to sort of like expanding outside of the hospital walls?
That is a great question, because funny, what I was able to do here at Children's National, I was just thinking about it at Methodist in Brooklyn. So I did hire ambulatory pharmacists. Their primary roles is discharge counseling, but not in the way of it's full service. Not only we're gonna educate you, but we're calling the pharmacy. We're getting that med delivered at the bedside. Before you go home, we're gonna make sure you understand it. It's in your right language. It's a complete assessment that we want to make sure that I work in a children's hospital, that our patients' parents or caregivers truly understand how to manage the medication piece of the treatment. And that way, little Susie, little Johnny doesn't come back before 30 days, right? We all know we don't want those readmissions, but also that there's a progression. We can see the patient at the clinic visit. So yes, I was able to hire ambulatory pharmacists just for that role. And it's funny, I have 4. We're a 325 bed hospital. I probably need another 4 more because it has been wildly successful. And now as we continue on with the pharmacy and expanding to the retail side, I will have a specialist that can work and really assist in that continuity of care. So ambulatory pharmacists are absolutely, it is a positive ROI, return on investment. And it's in all angles. They help close the chart, with the notes, as I mentioned earlier, with the indications and so forth. So there's so much value with ambulatory pharmacy. Huge. Big advocate.
And if I may add a comment on this, as more care is shifting from the inpatient space to the ambulatory space, so does pharmacy. And that's why maybe 20 or 30 years ago, you would see an inpatient pharmacist or a retail pharmacist. And now we're seeing more and more ambulatory pharmacists who work in physician offices and primary care and specialty care, because that's where we're trying to keep the care of the patients so they don't end up in a hospital bed. So it's a transition in healthcare, and pharmacy is just part of it.
Absolutely. I think one of the things I would add before we move to the next question is that we're seeing new roles that pharmacists are taking. Pharmacy roles in with a business lens, right? Pharmacy roles with an operational lens. And so I think some of that in continuing to, like, again, what kind of path does a pharmacist want to take to their role in leadership can be very many. Okay, question number 2. This is for you, David. How are you integrating innovative strategies into pharmacy? Think about how you're working with your health plan. Are you leveraging AI or other sort of data and analytics? How are you using new and sort of innovative processes and technologies?
Yeah, it's a great question. And I know we're short on time. I'll try to be brief. You can expand on it if we need to, Nicole. I'll look to you to lead me on that. But yeah, so how to integrate them? I think that I'll go back to what I was saying earlier of like asking kind of executives, if I ask our CEO or our strategy group, if I gave advice to somebody, if that's what the question's about, go find the strategy group, find the innovation group, find the business development group and say, what are the big things we're trying to solve and how can I help? Or I can help with those things. I have a point of view. I can build a specialty pharmacy. You know, I mentioned that it's been a huge part of our fiscal stability as a health system. I asked for help from our strategy group, who did a ton of analytics to help me. What the brief story was, we had $140 million of growth, but I knew some of it was locked out on PBM. Some of it was, you know, things that we couldn't, you know, perhaps access and buy. But the analytics group were able to like bring in a whole type of thing that I didn't have, and emerge with a very different set of answers. $65 million, 4 clinics, 50 doctors, and 500 patients. The way that our model emerged was very different because we invited something that was new and different, and a whole kind of data analytics group that was just emerging as popular 10 years ago to help us form our strategy. And then, you know, that has included how we work with the health plan. What are the main things, the key drivers? You know, John Goldie, who you know, who's our assistant vice president for analytics, my colleague, I look to him to say, what are the cost trends in pharmacy? What are the cost trends at the health plan in general? And how do we help solve them? Because I have a point of view on that. And that has gotten us at the table and helped us, like, you know, get to the right solutions, including building a big specialty pharmacy or doing population health pharmacy led by pharmacy.
Fantastic. Very good. Okay, we have time, I think, for one more. Mo, you gotta be quick on your feet on this one, okay? So we talked a little bit about moving from cost center to revenue center, lots of ideas and passion, but there's this one question. I love to ask this question. What would you have done different or sooner to create success, looking back on what you did over those years to create growth within pharmacy?
Yeah, I would have moved more of our services to the outpatient setting sooner and faster. That's where patient care is headed. That's where we're seeing more and more patient services staying in the office, staying in the outpatient space. Health systems traditionally focused more on the inpatient side, trying to optimize automation on the inpatient side, trying to solve for problems we face on the inpatient side, like drug shortages. All of these are still valid and very, very important, and we need to solve for them today. But as we're seeing more and more patients staying on the outpatient side, we needed to move pharmacists out to the outpatient side sooner. In my prior life, we moved them out to the outpatient space about 10 years ago, and I thought at the time we should have moved them even before then. Where we have pharmacists in primary care clinics. Imagine a patient going to the office to see the pharmacist for that day because they have a pharmacist visit where the pharmacist will look at their medications, optimize their therapy, and if they are taking medication that they should not take, we had an initiative called de-prescribing. Well, in a traditional fee-for-service world, you don't want to de-prescribe anything because you want to bill for it. You want to dispense it. But when you focus on patient care outcomes and population health, you want to do what's right, even if it meant less work and less revenue. Sorry for this long answer.
No, this is great. But I do think we have come to our close of time. I will say this, though. I think I speak for all of us on the call that all of you would be happy to be a resource to provide answers to questions, excuse me. And certainly Clearway Health is a resource to any of the attendees or friends or colleagues. And so with that, I want to say thank you to all three of you. I really appreciate your insights, your expertise, and your partnership. And so with that, I'll pass it to Randy to wrap us up today. Thank you.
Nicole. That's all the time we have for today. I want to thank you, Eric, David, and Mo for an excellent presentation and Clearway Health for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thanks for joining us and have a wonderful afternoon.